Okay, so renal. We're going to talk about this lovely organ we call the kidney. Just kidding. Okay. In order to understand renal failure, we need to cover what the kidney does. The kidney is, and some of you have heard me say this, it's kind of like the underdog. It controls so many things and influences so many things, yet all we ever really talk about is the brain, the heart, and the lungs. Though those are essential, the kidney does a lot, okay? So what does the kidney do?
Filters the blood.
Okay, so it filters
Releases
hormones,
Helps with acid base. Balance.
acid base,
It can
fluid
reabsorb.
volume, right?
Vitamin D activation.
Vitamin B activation?
D.
Vitamin D activation. What else?
Helps with blood production.
Okay.
Oh yeah, it releases something.
The
Europoietin.
Erythropoietin.
Erythropoietin. There we go. That for the red blood cells for the production. What else? Filters,
Helps with blood pressure.
Blood pressure. What's the system that it,
Renal, aldosterone, angiotensin.
so the
Angiotensin,
angiotensin system, right?
Renin.
Tensin, is it an O or an I? I.
tensin.
Okay, the renin-angiotensin system. That's a lot of stuff, right?
Yeah.
Okay, so if you remember what the kidney does, then from here you can think about, well, what if it doesn't work? Okay, so what if our kidney doesn't work? What happens with each of these?
It doesn't
So
filter
it doesn't
phosphate
filter the blood.
Acid base is off.
Creatinine,
Okay.
increase in creatinine.
So build up,
Of waste.
okay,
Acid
of
base is
waste.
off. So you
High
have
blood pressure.
the acid base. Now what, how is the acid base gonna be altered?
Well, bicarbonate will be effective, so like this.
So the
acid
kidney
base.
can't,
It can
can't hold
excrete.
on to the bicarb, right, to make, to buffer the acid. So we're most likely gonna have some acid issues. What else?
With the acid base, I was reading and it said that the calcium would be low, and sometimes the magnesium would be high, the potassium would be high.
So electrolyte imbalances again?
Yeah, electrolyte imbalances too, because it excretes potassium.
Potassium high, phosphate would be high.
Yeah.
What else? Hypovolemia? No, not hypovolemia. Hypervolemia. Is that what you said? I just didn't hear you?
Because you
Yeah,
have a buildup
fluid
of fluid.
retention.
So fluid overload. What else? What happens if, what hormones are we talking about?
Aldosterone?
The yeah, so do we want to put that here?
Yeah, because it's running aldosterone, angiotensin.
So we'll just group that together. Vitamin D activation,
Vitamin D deficiency.
okay.
So that means we would
So you have like arterial.
anemia.
What does vitamin D do?
It helps.
It helps with the bone. Yeah, no.
Helps with the
Would it be anemia?
bones, helps with your calcium,
Arterial would be anemia.
okay? So perhaps some musculoskeletal, bone issues, right?
And that has to do with the acid base, because if the calcium's low, then that would correlate with the vitamin D activation.
Right. Erythropoietin, so the patient's gonna be anemic. What about their blood pressure? And there's a reason you guys are studying hypertension at the same time as renal failure. So you already now can identify all the signs and symptoms of renal failure, right? And then there's going to be a treatment for all of these. There's going to be perhaps a test. Are there any labs or diagnostic tests that we're going to do based on what the kidney does?
Creatinine.
GFR.
Okay, so we really don't care about the GFR. Though the GFR is a nice to know, someone cares about it, and it does give us more information about the kidney. As far as like complications, preventing problems, we really are going to deal with the BU and creatinine. Okay. Okay, and electrolytes. Is there anything else?
What about red blood cells? Urea.
So red blood cells, urea. Uric acid is really just with gout, not just kidney.
Potassium?
Yeah, with the electrolytes for sure. Okay. The diagnostic tests are going to be variable. Maybe an ultrasound, CT scan, but those aren't going to be like for every renal failure patient. Okay. And there are stages of renal failure. Not really important to know all that stuff. Nice to know. The higher the number, the worse you are. Just like cancer. Stage 3, stage 4 is worse than stage 1. Okay? But not something that you need to memorize. Okay? All right, so we've got our what the kidney does. We've got the signs and symptoms when it doesn't work. We've got the labs that we'll be looking at, right? I'm trying to move the board so it's in the video. Okay, so treatment. Well,
Would you do
yes,
hypertensive medication?
dialysis is on the list.
Hypertensive medications to keep your blood pressure down?
Yeah, so every renal patient, we're focusing more on end-stage renal. Acute renal, you're going to do more in 4th semester. But it's still important to know how to treat the acute problems that come up. So even if you have and you guys know, if you have a chronic illness, you can still have an acute exacerbation. So you've got the chronic illness, but right now you have this urgent situation that has to be treated right now, right? So you still have to know some of the acute stuff, but not necessarily all of the specifics of the acute renal failure, okay? So there are going to be drugs that every end-stage renal failure patient is on. So you're going to see ESRD, end-stage renal disease. You're going to see chronic renal failure. We use them in practice interchangeably. If you see end-stage renal failure or chronic renal failure, you can 98% assume they're on dialysis. That would be my thought. So if you're told a patient has end-stage renal failure, then you want to know, okay, where's their access? What kind of dialysis are they having? Okay. So those are some things that we use in practice interchangeably. But there's going to be some drugs that they're on, and if they're not on it, you're going to go, where is that drug? Because they have renal failure, I expect them to be on that drug. Okay, so antihypertensives. I'll put those here. I don't think that's in my thing, my video.
So treatment is for under dialysis is under treatment, and then medication is
I'm just going to do some meds here. So antihypertensives. Okay, so let's start at the top. Is there anything we're going to give routinely for the buildup of waste?
Diuretic?
How do diuretics work?
they get rid of fluid.
But what organ do they work with?
The kidney, so it might.
The
put
kidney.
pressure.
So are you gonna be able to give a drug that is metabolized or excreted by the kidney and have it work? No. So, though you will see that, because we're kind of like, well, we need to try everything, it's usually not effective, okay? If they are acute renal failure because they haven't had enough fluid volume, they've lost some blood, they have a stone, something like that, those are fixable, and so that's kind of a different story. But if you're talking about a renal failure patient, their kidney's not working, there's no reason for them to have a Foley catheter unless you just want to give them an infection. And there's no reason for them to have a diuretic. But I have seen them on Lasix strips and stuff. And it's just like putting more fluid in the patient. Okay, so they will be on antihypertensives. Anything for acid base that they are on routinely.
For potassium, you said insulin, right?
So that's good. Let's do the emergency stuff down here. We'll do that in a minute. These are just the routine meds. If you saw this list of meds, you go, oh, that patient's probably in renal failure. Okay, and that's kind of what I do in the mornings when I'm making you guys' assignments, when I'm looking through. What about, are there any drugs for any of these electrolytes?
Would you give something to replace the calcium or something?
You might give some calcium, okay? Calcium carbonate.
Oh, the vitamin D too.
Okay, so they might be on vitamin D. Some of you should know this because we had a lot of renal failure patients today. What's that big white pill that they take 3 times a day?
Mine didn't have any. He just had the hypertensive medication.
Sevelamer.
Yes.
What is sevelamer? Mine didn't have sevelamer.
It's a phosphate binder.
Oh, because calcium binds to phosphate.
So phosphate binder. There are others, but this is the one I see most commonly. And then this is for the calcium. And obviously the vitamin D replacement. Sorry, it's the end of the day, so okay, so the phosphate binder. There isn't anything we can give for potassium, like PO as a standard drug. What about for erythropoietin issues?
It's called,
Okay, so that's up here. Epigen or Procrit are related to the dialysis stuff, usually. Folic acid. How many renal failure patients did we have today on folic acid? Right, we give a lot of folic acid today. Maybe iron, not an all the time routine, but this will be all the time routine. And you gotta know this one, because when you guys take OB, you're gonna give that every day too, in the form of a prenatal vitamin. Okay? We got the blood pressure, the antihypertensives. Okay, so your patient is going to be on this combination of drugs. Okay? If they have dialysis, they're going to be on one of these to assist with red blood cell production, and it's usually on dialysis days. I'm going to put HD for hemodialysis days. So if you were to see an order for Epigen and it's Tuesday, and they get dialysis Monday, Wednesday, Friday, you would question. You'd go, really? Are we giving Epigen on a non-dialysis day? Maybe, but not usually. Usually it goes with the dialysis days. So what do we have to worry about with dialysis? What are some things? Okay, well, let's get more specific.
They can drop in fluid. It can get severely high.
Oh, during dialysis?
Blood
Okay.
pressure?
It can get.
So their blood pressure is going to drop in the beginning.
So you want to hold any antihypertensive.
So you want to hold their BP meds. It will drop no matter what, but depending upon the amount of volume that the patient has, how fast the dialysis nurse pulls the fluid in the beginning, it's all about technique. They sometimes, if they pull the fluid and the blood pressure is dropping, they can put some of the fluid back, and there's kind of a balance there, the fluid in, fluid out. And all we really care about is the net output. How much did you take off after all of the ins and outs and everything? Okay, so you've got to monitor that. How long does dialysis take? It takes about 4 hours. What is your responsibility when the patient is getting dialysis? What kind of a nurse is in the room?
Dialysis nurse.
What kind of a nurse is a dialysis nurse? They're an RN.
Oh.
Dialysis nurse is an RN, and they have gone to work for a dialysis company, and they've gotten, 6 weeks of orientation to learn how to be a dialysis nurse. That's what a dialysis nurse is. Okay. So they're going to hook up the patient, and they're going to sit with the patient. What is our responsibility as the primary bedside nurse? Does it change? No, absolutely not.
So it's too vital.
You still have to go in the room. You still have to assess your patient. You
Give them
still
their
have to
meds.
listen to their lungs. You still got to give them their meds. You've got to know about the blood pressure meds. You can ask the dialysis nurse if you aren't sure about like an antibiotic or something. If it's going to be dialyzed out, then obviously you're not going to give it. You're going to wait. If the patient's going to get blood or something, it's best if the dialysis nurse does it and puts it into the machine, because they won't risk the fluid overload like they would otherwise. Okay? You're still going to turn them. You're not going to turn them all the way. It's mostly going to be like a tuck a pillow or just tilt a little, but you still have to do all of those things. And I have seen where we're like, oh, well, there's a nurse in the room. I'm going to go do all these other 5,000 things I have to do. Well, that nurse is responsible for the machine, the access, and monitoring the vitals. But if something happens, they're only going to assist in how they can assist with the machine. They're going to give a little more fluid. They're going to stop dialysis, that kind of stuff. They are not going to treat the patient emergently, for whatever problem it is. Okay, so it's still our responsibility to manage the patient. And if you're not sure how to do that, because the dialysis nurse is in there, they got all their equipment, they're attached to the sink, they're sitting in there, and the patient's got the needles, and everything's kind of precarious, just talk to them. Collaborate with them, right? And say, I really need to do this with the patient. Is that okay? Sometimes they let them eat while they're on dialysis. Sometimes it's a firm no, they can't eat on dialysis, stuff like that. So you collaborate with the dialysis nurse and, figure out what they're okay with. Okay? So the most important thing to a dialysis patient is their lifeline. What is their lifeline? Their access. So if you see a patient that has ESRD or chronic renal failure, you need to say, where's their access? And you need to assess it early and often, okay? Because if something happens to them, that is the majority of the time the only thing that is going to save them, is having an access that works, okay? And so you have to be able to identify what's a permanent access, the fistula, the graft, or do they have a permacath, do they have a vascath, what those things look like, and what you're supposed to do with it. Okay, so if you have a temporary access, so let's say the patient came in, their renal failure, and what happens a lot is their access gets, their graft gets infected. They don't take them out. They put them in, and they stay in there forever. Okay, and I've seen patients or they clot off. I've seen patients where they have multiple accesses all the way up their arms. I've even seen one in a leg, not very many, and it was because they ran out of places to put it. because you gotta have an artery and a vein that they can, you know, anastamo stick together to work for dialysis. So if the patient comes in with an infected graft, they're gonna have to treat them for the infection, and they're gonna probably need a new graft. If it's clotted off, they're gonna try to declot it in the cath lab. They're gonna go in and put medicine directly into it and try to break up the clot in there. Otherwise, they're gonna get a new one, and the new one cannot be used right away. It has to mature. The body has to heal around it, because you're gonna have all that pressure. You have all that arterial pressure, venous pressure, to pull and push all that blood, so you can't just have like, you know, a brand new incision and access. Okay, so fistula, graft, and so how do we assess that?
Feel the thrill and hear the.
Right, you feel the thrill, you hear the bruit, and the patient should know what all those things are, you know, when you're assessing it. And also you're gonna look at the site, okay? So site, thrill, and bruit. And then if they have a permacath or a vascath, until it's mature, because they still have to have dialysis, right? Permacath is what it sounds like. It's a little more permanent, so it might be something they go home with while they're waiting for the graft to mature, okay? So it looks kind of like a central line, usually in the chest, not always, but usually, and they tunnel it under, and then when it sticks out with the two ports, and it's wrapped in gauze. That's how you know it's a dialysis catheter. There's a red and a blue, and it's wrapped in gauze. That means leave it alone, okay? You never infuse anything in a dialysis catheter unless it's an emergency and you have an order, okay? There was a very short period of time where we had vascaths that had an extra port, like the one we have on our mannequin, and we could infuse through there. It was awesome, because now we have like a dedicated central line almost. And I don't think, they must not have worked well, because I haven't seen them. We got all excited about them, and then they went away, and it's like, what happened? So that's how you'll know. So that's the permacath. The vascath is an emergency access that's really only for no more than a week's time. It can be in the neck, it can be in the chest, it can be in the groin, and it's just sticks straight out. It's a very large gauge, but again, red and blue, it's wrapped with gauze, okay? And that, so like I said, that's like an emergent thing. This is more in between while you're waiting for the graft to mature, okay? Okay, so that's kind of, that's it for that. Anybody need to take a picture or anything? Yeah, go ahead and stop it. I'll make a second one.